I'd like to thank Doctors Brendan Spiegel and Brian Lacey for the honor of giving this year's American Journal of Gastroenterology lecture and for the opportunity to speak on a topic that's been important to me for many years. Over the next half hour, we'll cover the full gamut of foregut endotherapy, beginning with a brief history, then focusing on currently performed endosurgical procedures and the specific conditions that they address, touching on future directions throughout the talk. Here we have a timeline of the important events in the field of gastrointestinal endoscopy, beginning in 1805 with the development of the light lighter. Then in 1868, Kussmaul performed the first gastroscopy, and in 1907, Chevalier-Jackson performed the first biopsies and foreign body removals. In 1957, the fibroscope was developed with the help of Basil Hershowitz. Then in the late 60s and throughout the 80s, we have the development of ERCP in the US, and finally in 2005, we have NOTES, or Natural Orifice Transluminal Endoscopic Surgery. Here are the founders of NOSCAR at the initial meeting that launched the NOTES movement. The group was formed by thought leaders from gastroenterology and surgery in an effort to meld flexible endoscopic technique with surgical principles. And the group was performing very unique procedures, including transgastric tubal ligations and appendectomies, transvaginal cholecystectomies, and transcolonic distal pancreatectomies, among others. However, translation of these procedures into clinical practice was limited by the tools we had at our disposal. In the early 2000s, this was the complete armamentarium: injection needles, snares, forceps, clips, stents, and some other ERCP equipment. The group then published a series of white papers to serve as a roadmap for the safe and effective development of NOTES, with this paper focusing on technical requirements, including improved means of peritoneal access and gastric closure, development of suturing and anastomotic devices and multitasking platforms, and improved means of controlling hemorrhage. Subsequently, societies, industry partners, the NIH and DoD contributed substantial resources to these projects. What followed was truly an explosion of innovation. Within a short period of time, we had all sorts of devices, including staplers that could perform full-thickness resection, multitasking platforms that offered bimanual control for tissue dissection and suturing. We had this thing. We had endoscopes with bidirectional elevators. We had platforms for peritoneal access. We had semi-robotic flexible endoscopes, graspers that could seal large vessels, and a variety of endoscopic suturing devices. However, by 2011, every one of these devices was eliminated. None were successfully commercialized, and NOTES was officially declared dead. This was for a variety of reasons, including insurers refusing to pay for NOTES or hybrid procedures, and the FDA taking a hard stance on NOTES applications. Nevertheless, the NOTES movement had several positive effects, including the development of single-port laparoscopy, and of course, like a phoenix rising from the ashes, flexible endoscopic surgery was born. In fact, the rather modest array of tools we had prior to NOTES has become rather extensive today, with a variety of electrosurgical knives and scissors, vessel-sealing graspers, multitasking platforms allowing bimanual control for tissue dissection, improved devices for hemostasis, endoscopic suturing devices and plicating platforms, and even anastomotic devices, all of which are FDA approved and currently available. Additionally, some groups have resumed working on flexible robotics. For the remainder of the talk, we'll focus on the procedures that can be performed with these tools and the conditions they help us treat. These procedures can be broken down broadly into three categories: tissue dissection and resection, tissue apposition and remodeling, and tissue ablation. And we'll begin with tissue dissection and resection, focusing on myotomies, endoscopic submucosal dissection, submucosal tunneled endoscopic resection, and endoscopic full-thickness resection. There are numerous electrosurgical knives currently available, with various tip geometries designed to have specific effects on tissue, including insulated tips and tips that allow injection. There are also electrocautery-enhanced scissors, vessel-sealing graspers, and various caps available designed for specific purposes, such as tapered caps to assist with tunneling. The first condition we'll discuss is Zenker's diverticula. It was initially described in 1769, and the first surgical treatment was in 1877. It is a herniation of the esophageal mucosa posteriorly between the cricopharyngeal muscle and the inferior constrictor muscles. It is aligned with stratified squamous epithelium with a thin lamina propria, and there is no muscle layer. Symptoms are what you'd expect: dysphagia, regurgitation after eating, bad breath, and complications include aspiration pneumonia, esophageal obstruction, bleeding, and fistulization. There are a variety of treatment options available, including an open surgical approach, which is a transcervical diverticulectomy with cricopharyngeal myotomy. The technique is highlighted in this brief video. They start with a skin incision and then perform soft tissue dissection to expose the diverticula. And then in this case, they're stapling across it and will remove it. They'll then place a drain and close the area. ENT offers transoral approaches as well, including a stapled diverticulotomy as seen in the image, and they can do the same thing with a laser. And there are also a variety of flexible endoscopic approaches, which we will show you here. On the left, you can see we're using an insulated tip knife to divide the septum, and on the right, we're using electrocautery enhanced scissors. The technique is really rather straightforward. With modern electrosurgical generators, bleeding is kept to a minimum. It's important to use a cap, and we do perform these procedures under general anesthesia. And this technique is different than the Z-POEM technique, where you make a tunnel and then divide the septum and close the tunnel. However, as we'll be focusing a good deal on tunneling later, and there are more data around the traditional technique, that's what we'll be focusing on here. This is a meta-analysis with 20 studies and over 800 patients. You can see roughly 24% of these patients had received previous treatment, and the success rate was 91%, with an adverse event rate of 11% and a recurrence rate of roughly 11%. And these were mostly mild, so rather safe and effective. And we do anticipate that we'll have more data around Z-POEM in the near future. Moving down the esophagus, we have achalasia. The entity was first described in 1672 by Sir Thomas Willis, and in 1913, Heller performed the first surgical myotomy. Achalasia is Greek for does not relax, and is characterized by diminished or absent peristalsis and a failure of the lower esophageal sphincter to relax. Pathophysiology includes a loss of ganglion cells within the myenteric plexus here between the longitudinal and circular muscle fibers, a loss of inhibitory nitric oxide ganglion function, and relatively intact cholinergics. The diagnosis of achalasia is made on high-resolution manometry, and our three types of achalasia are here. What's common among them is impairment in lower esophageal sphincter relaxation and a loss of peristalsis. In type 1 achalasia, we also find relatively low distal esophageal pressures of less than 30. In type 2 achalasia, to the left here, we have panesophageal pressurization with pressures typically greater than 30. And in type 3 achalasia, we find spastic contractions of the distal esophagus. The Icar Score is a symptom score that can help you track the progress of patients. It's composed of weight loss, dysphagia, retrosternal pain, and regurgitation. A score of less than 3 is considered normal, and a score greater than 9 in some studies has suggested that patients may not respond as well to POEM. There are several treatment options available, including medical, endoscopic, and surgical, and I'll be focusing primarily on POEM and Heller myotomy with door fundoplication. This animation highlights the basic steps in the typical EPOEM technique. We begin with a submucosal injection and access into the submucosal space. And then we create a tunnel roughly 10 to 12 centimeters in length, extending at least 2 centimeters beyond the lower esophageal sphincter. This is then confirmed endoscopically. The myotomy is begun roughly 2 to 3 centimeters distal to the access site and extends again roughly 2 centimeters distal to the LES. And the access site is then closed with clips or suturing. Several questions still remain regarding optimal technique, including anterior posterior position of the tunnel, full thickness versus partial thickness, length of myotomy. However, as you'll see, the outcomes are still pretty decent. This is a table from a review looking at long-term outcomes from POEM, and you can see there's a relatively good number of patients here with follow-up ranging from 12 to 36 months. Clinical success typically in the 90s to 100% here, with one a little lower. Icar scores tend to improve below 3 across the board. LES pressures also improve rather considerably. And the one thing to watch out for here is Gerd, which clinical Gerd seems to appear in the high teens to low 20% range. So, how does EPOM compare to laparoscopic hilar myotomy? Well, this meta-analysis asked just that question. It included 74 studies with over 7,700 patients. Over 5,800 patients had undergone laparoscopic hilar, and over 1,900 patients had undergone POEM. The follow-up period did differ significantly between these groups, as worth noting, shorter for the POEM group. Overall success was higher in the POEM group at 93% versus 88%, and the predicted probabilities for success at both 12 and 24 months also significantly favored POEM. However, Gerd symptoms were also higher in the POEM group at 18.5% versus 17.5%, and the odds of Gerd on pH monitoring were also roughly 4 times higher in the POEM group. Moving on to gastroparesis and GPOEM. Gastroparesis is, of course, often a chronic condition that's characterized by delayed gastric emptying and affects up to 4% of the population. Etiologies of chronic gastroparesis include diabetes, post-surgical, and idiopathic. And the mechanisms here are either alteration in gastric motility or increase in pyloric tone. And the GPOEM technique, very similar to what we showed you for EPOEM. Again, you're creating a tunnel, performing a myotomy, and closing the tunnel. The body of literature around GPOEM is, of course, less robust. However, we do have this meta-analysis of 10 studies with 281 patients that shows a significant improvement in the gastroparesis cardinal symptom index score here, as well as a significant improvement in 4-hour gastric emptying scintigraphy. However, the quality of evidence via the grade methodology was of low certainty for the GCSI and very low certainty for the GES. But I do believe we do have some RCTs that will hopefully be underway soon. Moving on from myotomies to tissue resection. Of course, we know that ESD was pioneered in Japan for early gastric cancer for some years before being formally defined in 2003. There are multiple techniques that are still in evolution, including pocket ESD, the use of retraction devices, and modification of electrosurgical waveforms. One constant here is we like to think of degree of tissue invasion to determine who's eligible for these procedures. And we know M1 and M2 are safe in the esophagus, but when we get to M3 and SM1, we have a higher rate of lymph node involvement, up to 15% of the time. In the stomach, we can afford to go a little deeper. M3 and SM1 may be fair game there. I'm showing these videos side by side to illustrate the differences between ESD and STIR. On the left, we're marking and lifting the lesion, and on the right, we're entering the submucosal space to create a tunnel. On the left, we'll then make an incision circumferentially around the lesion, and on the right, we'll dissect out the submucosal lesion. Now, STIR is designed specifically for submucosal lesions. However, you can use a similar technique for mucosally based lesions called pocket ESD to help with the submucosal dissection. We'll then remove the lesion from the tunnel and have to close that access site on the right. And on the left, we'll look for any exposed vessels and cauterize those, and we could consider closing that defect if indicated. This meta-analysis looked at gastric ESD versus surgery and included 18 studies with nearly 6,000 patients and found that ESD was associated with a lower risk of procedure-related death and overall complications. However, it was also associated with lower rates of curative resection, higher rates of local recurrence, and lower disease-free survival rate. However, there was no significant difference in overall survival between groups. While the myotomies and various advanced endoscopic tissue resection techniques continue to gain ground and prove efficacy, why is it that relatively few centers in the United States routinely offer these procedures? Well, it's for a variety of reasons, including relatively long learning curves, technical issues with tissue retraction, among others, and reimbursement issues. But many of these devices are aiming to address those problems, and most are already through the FDA and are now trying to make their way into routine clinical practice. Next, we'll move on to tissue apposition and remodeling, focusing on general endoscopic suturing, anti-reflux procedures, obesity therapies, and anastomosis formation. And here we have the basic steps of endoscopic suturing. First, tissue is acquired, then a handle is activated to drive the needle through the tissue. The tissue is then released. The handle is then again activated to close the needle driver and reload the needle. Here we have the room and endo view. We close the handle to drive the needle through the tissue. We pick up that needle, back up. We'll then close the handle again and reload the needle onto the needle driver or the suturing arm. Suturing has been rather enabling for endoscopists, allowing us to contend with all sorts of issues, such as this relatively large perforation in the jejunum of a gastric bypass patient. We can now address these more like surgeons would. We can control the pneumoperitoneum by inserting an angiocatheter under direct visualization. We can explore the abdomen for signs of peritoneal soiling that might require surgical intervention. We can consider an omental patch by pulling that omentum in, freeing it up, and pulling it in towards the defect. Then, of course, we can close the defect with suturing, which is more secure than other methods. There aren't a lot of data here, and this is a retrospective review of colon perforations. And you can see 5 of these patients were treated with clip closure and 16 with sutured closure. And 4 of the 5 clip patients required further intervention, where only 2 of 16 sutured patients required further intervention, and both of those were confirmed to be adequately closed. So they concluded that suturing is superior to clip closure. Endoscopic suturing devices are rather versatile, as they can perform a variety of suture patterns, including interruptives, mattress, running, and purse strings, and this makes them broadly applicable to a variety of conditions, including various closure procedures for perforations, access sites, fistulas, and leaks, ulcer oversewing, GI bleeding treatment, and of course, bariatric and anti-reflux applications. And that's our segue to Gerd and GE junction anatomy. The high pressure zone of the GE junction consists of extrinsic components, including the costal portion of the diaphragm and the crus, and intrinsic components, including the circular muscle fibers of the intra-abdominal esophagus, as well as the gastric sling fibers and the clasp fibers in the cardia. There's been some nice physiologic work done in this area on ventilated patients that are given either atropine or cystatricurium to isolate the extrinsic and intrinsic components. And you can see here, this is the pressure from the extrinsic components in green and the intrinsic components in blue. And the blue is 2-spiked, with the distal spike representing the sling and clasp fibers. In patients with reflux in Hill grade 2 or 3, you see a loss of this second spike, and that shows the importance of the sling and clasp fibers. As a result, most endoscopic devices focus on sling and clasp fibers, as they cannot address the extrinsic components at the present time. Here you see an animation of the Tif procedure, where tissue is acquired and the device is rotated, then suction is applied and the device is advanced, and H fasteners are then deployed. And this is repeated, and the result is a 270-degree valve with elongation of the intra-abdominal esophagus. And this is what it looks like clinically. We acquire tissue, rotate the device towards the lesser curvature and place application. We'll then unrotate the device and release the tissue. Here's a before and after video on one of my patients. On the left, you see a patchless LES, and on the right, it's a good bit tighter with a visible H-bar fastener. And on retroflexion, you can see that nice, robust 270-degree valve. This is a meta-analysis of 32 studies with over 1,400 patients that had undergone TIF. And you can see at 1 year, there's a significant reduction in mean acid exposure time, and most patients were able to come off their PPIs. There was also an improvement in questionnaires across the board. There's also a long-term cohort study which showed improvement in subjective measures out to 10 years, with over 40% of patients remaining off PPIs and another substantial portion significantly reducing their PPI use. However, there was a rather substantial loss to follow-up. Moving on to obesity and endoscopic, bariatric, and metabolic therapies. These procedures can be broadly classified into 2 categories, either gastric devices, such as intragastric balloons, or gastric remodeling, such as plicating or suturing, or aspiration therapy, or small bowel devices, sleeves, duodenal mucosal resurfacing, which is a ablation technology, or anastomotic devices. We're currently trying to better understand how these procedures work, and the homeostatic mechanisms that govern weight and appetite are rather complicated. However, it's believed that if we can prolong gastric emptying, this can lead to a reduction in ghrelin levels and thus suppress appetite. And this is the proposed mechanism for intragastric balloons and some gastric remodeling procedures. Alternatively, it may be possible to speed gastric emptying and trigger hindgut effects, such as increasing GLP-1 and other incretins, and that this can also suppress appetite. And that's the proposed mechanism for other gastric remodeling procedures, as well as various enteric devices that can alter the flow of food and bile through the small bowel, triggering similar effects. In 2008, we performed the first in human primary bariatric suturing procedures focusing on the greater curvature. Unfortunately, at the time, we did not have a full thickness suturing device, so although there was good initial weight loss, there was limited durability. Then in 2012, our team, together with Rob Hawes, performed the first in human ESG procedures using the newly available full-thickness suturing device and a suturing pattern very similar to our prior procedure, focusing on the greater curvature. We performed this in a total of 126 patients across multiple centers, and the results were quite striking. You see a BMI reduction from 36.2 down to 29.8, and a total weight loss of just over 19% at 6 months. There's been a considerable amount of work done in the field since that time, and we now have a meta-analysis on endoscopic sleeve gastroplasty, including 8 studies and over 1,700 patients, and the 1-year efficacy is 16.5% with a serious adverse event rate of 2.2%. The most concerning thing there are leaks and fluid collections if we spend too much time suturing the fundus. We also have data on 5-year outcomes from a single-center retrospective study out of Reem Shariah's group. And they looked at a total of 216 patients, 68 of which were eligible for 5-year follow-up. And they found a 15.9% total weight loss at that time, with 90% of patients maintaining at least 5% total weight loss and 61% of patients maintaining 10% total weight loss. 27% of patients were started on pharmacotherapy over that time, and the adverse event rate was only 1.3%. Moving on to endoscopic anastomosis and lumen-opposing metal stents. These were, of course, initially cleared for the drainage of fluid collections. However, they've been found to be useful in the formation of gastroenteral anastomoses, gallbladder drainage, and a variety of other indications. Additionally, newer systems, such as magnetic anastomosis systems, are also being studied in the treatment of obesity and diabetes. And we'll start with necrosectomy. Here we have a randomized controlled trial that included 22 patients and had a composite clinical endpoint, including major complications, new onset organ failure, new onset diabetes, and death. And you can see endoscopy outperformed surgery across all those parameters. However, this technique was not broadly adopted until the development of lumen-opposing metal stents. And you can see here, initially you just place a catheter into the cavity, release a distal flange, pull back, release a proximal flange, and it's rather straightforward. The most common indication for LAMS in our institution is malignant gastric outlet obstruction. And here we see we're performing a gastroenterostomy where we release that distal flange in the small bowel, we'll pull back and release the proximal flange in the stomach. And this is, of course, after distending that small bowel with fluid and contrast. Several different methods for this have been described, including a double balloon method where they create a small chamber of fluid as a target. However, we do prefer the freehand approach. Next, we have a meta-analysis looking at the use of LAMS to treat gastric outlet obstruction. It included 12 studies and 285 patients. And you can see technical success and clinical success were both over 90%, with recurrence of symptoms at 9% and a 12% adverse event rate. So, how do LAMS compare with enteral stents? Our group published a retrospective review of 100 patients, 78 of whom had undergone enteral stent placement and 22 underwent LAMS placement, and the primary outcome was reintervention rate. And you can see here that 32% of the patients that had enteral stents required reintervention, where only 8.3% of patients who had the LAMS required reintervention. As far as secondary outcomes, technical success was similar between groups. However, clinical success was higher again in the LAMS group, and adverse event rate was somewhat lower, but this did not reach statistical significance. And finally, we have gallbladder drainage. And this video is of one of the original procedures performed by Professor Moon. He's using an over-the-wire technique. And here we have a multi-center randomized controlled trial for drainage of inoperable acute cholecystitis. 80 patients were randomized 1-to-1 to either EUS drainage or percutaneous drainage. Both 1-year adverse events and reintervention rates favored EUS drainage with statistical significance. Additionally, only 15% of patients in the EUS group required unplanned readmission versus 50% in the percutaneous group, and only 2.6% of patients in the EUS group developed recurrent cholecystitis versus 20% in the percutaneous group. And pain scores and analgesic requirements were also lower in the EUS group. And on to our last section, which is tissue ablation procedures. Ablation has certainly been best characterized in the treatment of Barrett's esophagus. And here we have a landmark study from Nick Shaheen. It was a multi-center sham-controlled trial of patients with dysplastic Barrett's. They were randomized 2-to-1 RFA versus sham, and the primary outcomes were complete eradication of dysplasia and intestinal metaplasia at 12 months. Here we see, as far as complete eradication of low-grade dysplasia, it was over 90% in the RFA group versus only roughly 23% in the sham. And for high-grade dysplasia, there was an 81% eradication rate in the RFA group versus 19% in the sham. Regarding complete eradication of intestinal metaplasia, this was over 77% in RFA versus 2.3% in sham. So this is a very successful, well-characterized procedure. Ablation therapy has also been shown to halt the progression of Barrett's esophagus. And here we have another randomized controlled trial of 136 subjects randomized 1-to-1 to RFA versus endoscopic surveillance. The primary outcomes are listed here, and you can see that 1.5% of patients in the RFA group progressed to high-grade dysplasia versus 26.5% in the control group. And similarly, 1.5% in the RFA group progressed to adenocarcinoma, with 8.8% progressing in the control group. Regarding secondary outcomes, these confirm the results of the prior New England Journal study regarding eradication of dysplasia and intestinal metaplasia. There are also numerous devices under investigation, including various forms of cryotherapy and hybrid APC, among others. And finally, we have duodenal mucosal resurfacing. And this is a metabolic therapy aimed at treating type 2 diabetes. And you can see it's a catheter-based system, and this is advanced over a wire into the small bowel. And then tissue is aspirated into these small channels that run on the outside of the balloon, and a needle is advanced into the submucosal space, and fluid is injected, creating a submucosal cushion. The water is then heated in the balloon, and the mucosa is ablated. And this is repeated throughout the duodenum. The concept here is that they're trying to reset stem cells and block anti-incretin signaling. However, the exact mechanisms are yet to be determined. And here we have the results of a multi-center single-arm study. And you can see the baseline characteristics here. So average BMI of 31.6, so not terribly obese, but they do have poorly controlled diabetes with an average A1C of 8.6. And they have really improvement of all glycemic indices across the board, with a drop in A1C from 0.9 to 1.4%, improvement in HOMA-IR, and the like. What's also very interesting is improvement in hepatic fat. So here you can see the MR hepatic fat fraction, and there's a 30% lowering in relative fat and a 6% reduction of absolute fat. In conclusion, there's been substantial progress made in this field over the last 15 years. In fact, we've entered a new era in endoscopy, and that's one of endoscopic surgery. Since notes, endoscopies replace traditional surgery for many foregut conditions, as we've discussed today, and I believe that's just the tip of the iceberg. If there's one take-home message, is that these procedures are real and that there's considerable evidence to support their safety and efficacy. So if you have patients with these conditions, consider referring them to your therapeutic groups, or perhaps consider learning some of these techniques for yourself. Thank you for your attention.